All right, let's jump right in. This is a high-yield clinical review of Alport syndrome. We're going to focus on the absolute essentials, the pathophysiology, the presentation, and the diagnosis. This is a crucial topic in nephrology and definitely a recurring theme on specialty board exams. So here's our game plan. We'll break this down into 4 key areas. First, we'll get to the heart of the matter, the core defect in Alport syndrome. Then, we'll look at its classic clinical features, walk through the definitive diagnostic pathway, and we'll wrap up with a really critical, high-stakes post-transplant complication. Okay, let's start with the pathophysiology. What is the fundamental problem going on at the molecular level in Alport syndrome? If you really get this part, all the clinical signs and symptoms that follow will make perfect sense. At its core, Alport syndrome is all about a defect in type 4 collagen. To be specific, you've got mutations in the genes that code for the alpha-3, alpha-4, or alpha-5 chains of this collagen. This messes up the structure of the glomerular basement membrane, the kidney's main filter. And that single structural failure is really the root of the entire disease. Now, the inheritance pattern here is clinically critical. About 85% of cases are X-linked, which is caused by mutations in the COL4A5 gene. And this has huge implications for how severe the disease is and how it presents, as we're about to see. The other 15% are usually autosomal recessive, involving different genes, COL4A3 or COL4A4. So, that X-linked inheritance explains this really significant difference we see between sexes. Males, right, they only have one X chromosome, so they get the full severe disease, and it typically progresses to end-stage renal disease pretty early in adulthood. Females, on the other hand, are heterozygous carriers. Because of random X chromosome inactivation, what we call lionization, they end up with a mix of normal and defective basement membranes. This leads to a much more variable and usually much milder clinical course, often just limited to microscopic hematuria. Okay. So now that we understand the genetic defect, let's look at how this all translates into the clinic. How does a patient with Alport syndrome actually present to you? Well, the presentation is a direct result of where type 4 collagen is important in the body. The classic triad involves the kidneys, the ears, and the eyes. For the kidneys, it progresses from microscopic blood in the urine in childhood to full-blown proteinuria and eventually end-stage renal disease. But it doesn't stop there. Type 4 collagen is also essential for the structure of the cochlea in the ear and the lens of the eye. This is why we see bilateral sensorineural hearing loss and specific eye problems, most famously anterior lenticonus. So let's say you're presented with a patient, maybe a young man with hematuria and a family history of kidney failure or hearing loss. Your clinical suspicion for Alport syndrome is going to be pretty high. So how do we actually lock in that diagnosis? The diagnostic journey starts with that clinical suspicion, which is really bolstered by the family history. Now, traditionally, a renal biopsy was the gold standard, but today, molecular genetic testing is often the first step because, well, it's non-invasive. That said, a biopsy gives you that definitive histopathological proof, and it can be absolutely crucial if the genetic tests come back inconclusive. And when you do that renal biopsy, what you see under electron microscopy is absolutely pathognomonic. The lamina densa of the glomerular basement membrane, which should be this smooth, consistent layer, shows this characteristic splitting and lamination. This is the direct visual evidence of that faulty type 4 collagen network. This splitting and layering of the basement membrane creates what is famously described as a basket weave appearance. This is a huge buzzword for exams. Seriously, if you see this term in a clinical vignette, your mind should immediately jump to Alport syndrome. It's that specific. All right. Finally, let's tackle a critical post-transplant complication. This scenario is clinically very important, and it's a concept that gets tested all the time. So let's consider a patient with Alport syndrome who has just received a kidney transplant. So picture this. The transplanted kidney is a good match. It works well at first, but then, all of a sudden, the patient develops a rapidly progressive glomerulonephritis. What is the immunological mechanism that's driving this graft failure? What's going on here? So here's how it works. The patient's immune system has never, ever seen normal type 4 collagen. Their genetic defect meant they just couldn't make it. So when the healthy transplanted kidney comes in, it introduces this normal collagen as a brand new foreign antigen. The immune system then mounts a response, creating anti-GBM antibodies that attack the new kidney's basement membrane. The result is a post-transplant anti-GBM disease that looks and acts just like Goodpasture syndrome. Okay, let's wrap this up with the critical takeaways. The core defect is in type 4 collagen. Inheritance is mostly X-linked, making it more severe in males. The classic features are that triad: renal failure, sensory neural deafness, and lenticonus. The pathognomonic biopsy finding is that basket weave appearance, and the key complication you have to remember is that post-transplant anti-GBM disease. So, to finish up, let's think about the future. What are the implications of early genetic diagnosis? As we get better at identifying these mutations before symptoms even start, what new opportunities open up? Could we intervene earlier with things like ACE inhibitors to delay renal failure? Or maybe one day could targeted treatments fix the underlying collagen defect itself, preventing not just the kidney damage, but the hearing and vision loss too? This really is the future, a shift towards proactive, personalized medicine for these kinds of inherited kidney diseases.